Okay, today we're going to learn about malaria. Yes, I haven't done one of these in a while. No, I will probably not be any more consistent in the future. And no, I don't care if I said I was going to do something else. We're learning about malaria. Malaria, it's a potentially life-threatening disease caused by the Plasmodium parasite, and it's transmitted via the bite of an infected female Anopheles mosquito. Of course, nothing in medicine is ever that simple, so there are actually 5 different Plasmodium species that we care about because those are the kinds that can infect humans. And in classic medicine fashion, they're very, very similar while also being super fucking different. So let's just begin with this. Plasmodium is a unicellular protozoan parasite. And here are the 5 types that we care about. First, we have Plasmodium falciparum, and this one is the shittiest, so of course it is also the most widespread. We have Plasmodium vivax and Plasmodium ovale, and both of those tend to be relapsing. And we have Plasmodium malariae, which is easy to remember because it's the only one that actually has malaria in its name. Hilariously, tends to be the least severe. And finally, we have Plasmodium knowlesi, which I deeply resent having to talk about at all, but I will because knowledge, I guess. It's pretty rare, and I hate it. Just kidding. It's zoonotic, which means we get it from primates, and it looks a lot like Plasmodium malariae. So we often misdiagnose them for each other, which is bad, obviously, because you need to know what disease you're treating when you're treating it. Knowlesi is also usually worse than malariae, so it's not good to mess up on that. But if you care about it, you're welcome to look up more because I'm tired. And obviously, there are changes to the Malarian clinical picture. That's not a sentence. What I'm trying to say is there are changes to the clinical picture depending on which type of malaria you have. And I'll talk a little bit more about that later, but for now, we're just going to kind of discuss fevers as an example of that. So, vivax, ovale, and falciparum are all considered tertian malarias, which means that they are characterized by fever spikes, or if we're being, medical fancy, febrile paroxysms every 48 hours. So then you can compare that to Plasmodium malariae, which is a quatern malaria, which means it has spikes every 72 hours. Yes, I did just say that Plasmodium falciparum is a tertian malaria. And I'm not wrong, but I am also kind of not right either. Some patients will experience spikes every 48 hours, and others won't. So remember when I said falciparum is the shittiest of the malarias? It's because its spikes can either be irregular. I mean, that's not why, but it's part of why I consider it the shittiest malaria, is that its spikes can be irregular or they can be every 48 hours. And we call this a malignant tertian malaria, which I can only assume is because the medical community is really shitty at naming things. Fuck you, fine. Plasmodium knowlesi is a quotidian malaria, which means it has irregular spikes. Don't ask me why knowlesi is quotidian, but fucking falciparum is malignant. I'm not in charge of naming things. Great. Okay, so with that out of the way, how does this actually work? So first things first, we're going to recap our knowledge of the mosquito life cycle, because obviously you have such knowledge about the mosquito life cycle. Well, first things first, the female mosquito will lay eggs inside containers holding water, like buckets or lakes. The second step is obviously the eggs will hatch, and they'll hatch somewhere within a few days to a few months, depending on when they're fully submerged in water. The larvae are aquatic, and they will develop into pupae in as little as a few... It's so gross. I don't want to talk about it. Okay, so they'll turn into pupae in as little as 5 days, is the sentence I was trying to say before, and then the pupae become adults in about 2 to 3 days. And this is important, mostly from a public health perspective, because if we can stop mosquitoes, then we can stop malaria. Also, knowledge is power, etc., etc. I don't know. I would like to never know these facts, but we'll know them forever now. Yeah, let's talk about mosquitoes and malaria, the world's other favorite M&M, I guess. Words that I'm about to use that you've either heard a million times before and will resent me explaining, or you've never heard of them. The first is gamete. It's a mature haploid germ cell which can unite with another of the opposite sex to form a zygote. So think like egg and sperm. Then we have zygote, which is basically the babyest form of a cell that can grow and mature to become a thing, a real thing. In malaria, a female mosquito will feed on an infected individual, and the gametes from the blood will fuse. So gross. I don't like mosquitoes. Okay, so basically what happens is the gametes from the blood fuse in the mosquito's stomach to form a zygote, and we call that zygote an ookinet for some fucking reason. Ookinet. I think we just like to make funny words in medicine. That's my current running theory. Okay, and then ookinetes will mature into a thing that we call oocysts, and those will rupture to produce sporozoites. And sporozoites are these like sickle-shaped cells that initiate the asexual reproductive cycle in the new host, which in malaria is us. So then the infected mosquito will feed on a human and transfer these sporozoites from its salivary gland into the human blood, which is when things start to get funky. So the sporozoites will travel to the liver and they will infect liver cells until they can mature into something that we call a schizont cell. Schizont cells will rupture to release merozoites. And merozoites can actually reproduce sexually or asexually. So we have kind of like two things that can happen at this point. So the first thing is the merozoites can enter the erythrocytes or red blood cells, and then they can differentiate into gametocytes, where they can then be picked up by the next mosquito bite. Or the second thing that can happen is the merozoites can enter the erythrocytes, where they'll differentiate into trophozoites, which are ring-shaped. They're basically the feeding stage of the Plasmodium infection. And this is when we actually start to see the signs and symptoms of malaria, because the trophozoites in the red blood cells can mature into schizonts, kind of like in the liver. And then these contain like thousands of merozoites, which they release into the bloodstream, causing, fever and other symptoms. Plus the reoccurrence of the penetration of merozoites into the erythrocytes, right? They sort of self-perpetuate that cycle of fucking up your red blood cells. In Vivax, you'll actually see some of the liver schizonts become dormant, and then we call them hypnozoites, that one's actually kind of fun. And that's important because what will happen is like months later, they will reactivate and then they'll re-release, and sort of that causes that relapse that we talked about before. So you can also see that in Ovale. Fun sidebar time. Let's talk about recrudescence versus relapse, because why not? Oh, relapse is basically what I described above. It's the presence of the liver form of the disease sort of coming back or reactivating or whatever fucking useless word you want to use here. And then that causing a reoccurrence. Recrudescent is when the reoccurrence is actually caused by a persistence of a small number of the Plasmodium in the blood, right? It's not because of the liver form, it's because of it's in the blood. And you see that most frequently with falciparum. So now we get how you get it, kind of, sort, whatever. Don't worry about it. Let's actually talk about what it does. What are the clinical features? So first things first, malaria has an incubation period of a minimum of 7 days. So if your patient has a fever after like traveling to or being in an endemic region in less than 7 days, that's not malaria. Now, the flip side of that is it can incubate for like 30 days. So you do need to make sure, check. No less than 7, but, up to 30. And the general course of the disease is basically, the patient gets infected and then they'll have a asymptomatic parasitemia. Then they can have an uncomplicated version of the illness, and then they might get severe malaria and then they die. Ideally, not those last two things. Now, obviously, the course of the disease is going to be impacted by, a couple of things. The level of immunity in the host, the species of the Plasmodium that they were infected with, the timing of the treatment, all of this stuff is going to influence the severity of the course of that disease for that patient. All right, so let's start by talking about general symptoms or uncomplicated malaria, right? So the first thing we're going to obviously have is fever, which can be continuous or it can be remittent, right? And it's usually a high fever. Now, they might exhibit flu-like symptoms, so your classic, your headaches, your myalgias, your arthralgias. You can also have backaches. Patients might be sweaty. They might also be a little bit jaundicey, right? I just said a bunch of shit is happening in their liver, so that's not surprising. Patients might have lethargy. In children, you kind of want to be mindful of, you want to keep an eye on them. You want to look to see if they stop playing or if they stop eating, as normal, because that's kind of how you're going to pick up that lethargy and that pain, because, kids can't just be like, hi, I'm experiencing myalgia. Could you imagine, though? That would be stunning. Okay, so we're actually going to talk about some of the more severe manifestations, the more, scary signs and symptoms than just like having a flu. These tend to be caused by the infected erythrocytes kind of occluding capillaries, and that will lead to like organ dysfunction or, clots. Let's kind of just talk about what happens in the blood because you have a couple of different options, right? And then we'll talk through some of the really severe symptoms. Not that what happens in your blood can't be a really severe symptoms. I really need to start scripting these before I fucking talk. Anyway, okay, so thrombocytopenia is kind of one that you might see. That's basically an increased bleeding risk. And in severe cases, you might actually get all the way into disseminated intravascular coagulation. If you don't understand how thrombocytopenia leads to disseminated intravascular coagulation, Google is free. Things that you might see are going to be hemolytic anemia, right? So that's just going to be weakness and dizziness because malaria is destroying your red blood cells. And then you can also have hyperparasitemia, which is basically when greater than 5% of the red blood cells are infected with the plasmodium. So I should probably mention that these patients might experience nausea, vomiting, diarrhea, and also hepatosplenomegaly, which makes sense, you know, with what I said before, why the same reason as why they get jaundice. Like, a bunch of shit is happening to your blood and to your liver in the course of this disease. It's not pleasant. Okay, and now we're going to talk about bonus deadly manifestations of malaria, just like other things that can kill you in this disease. It's a fun time. Anyways, we're going to talk. So first things first, you can have cerebral malaria, and that's going to present with like hallucinations, impaired consciousness, seizure, coma, death. You can have renal implications, right? Obviously because of the blood. So you're going to see flank pain, oligonuria, hemoglobinuria, acute kidney injury, right? So you want to treat that very carefully. You want to be hydrating those patients. You want to make sure that they get transfusions if they need them. We'll talk about treatment later. I don't need that now. There's a ton of cardiopulmonary symptoms that you need to be aware of. First, obviously, is heart failure. That's bad. And then pulmonary edema. These patients are at high risk for ARDS and obviously shock. All of these are super deadly if not managed. Finally, malaria can have metabolic effects, right? So you need to be mindful of the fact that these patients might fall into a hypoglycemic crisis or metabolic acidosis. Basically, malaria can present in a bunch of different ways. So if you have a patient who has a fever, who has traveled to an endemic region, consider malaria. Just put that on your differentials. Now, Yara, you may ask, you keep fucking saying endemic region. What does that mean? What a good question, my fine invisible friend. So most cases of malaria occur in tropical Africa, aka West and Central Africa. But you'll see that in other tropical, subtropical regions like in Asia, you know, India, Thailand, Indonesia, and parts of Latin America, aka Brazil and Colombia. My knowledge of geography is very suspect. So I'm really sorry if some of that was wrong. Okay, awesome. So now we have a patient with a fever who came from one of these regions, and since you were listening so raptly earlier, you now are like, oh shit, I suspect malaria, but how do I prove it? You're going to do a blood smear. So a blood smear should confirm malaria by visualizing the parasite. And there are all of the different plasmodiums. They all look slightly different and whatever, etc. It's a useful skill that I don't have. So the first thing you're going to do is a thick blood smear, and that should just confirm that it exists, the presence of the parasite. It's highly sensitive. And then you'll move over to your thin blood smear, and that is got a lot higher specificity, so it can help you kind of identify which plasmodium are you actually dealing with. Listen, if I was gonna be good, right now I would pause and I would describe to you what you would see on the thin blood smear for each of the different plasmodiums and how you might identify one from the other, but I don't know that. So, here's what I got for you. If you see like a fine brick red dots in the cytoplasm, those are things called Schuffer granules, and that is like Vivax Arovale. And if you see like multiple infections of red blood cells, you know, ring forms, that's probably falciparum. And if you see anything else, consult a specialist. Also, it bears mentioning, if your blood test is originally negative, don't rule out malaria just yet. So what you need to do is you want to repeat your blood smears 3 times every like 12 to 24 hours, because the parasite densities can be really, really low, especially at the beginning of the infection. So it might initially be undetectable. Undetectable. So you want to get at least 3 sets of negatives over a period of time before you can actually rule out malaria. Here's some other stuff that you can do that you probably won't, but we'll talk about it anyway. So you can do the rapid diagnostic tests, or RDTs, and those tests for specific malaria antigens, right? HRP2, PLDH, and aldolase. And basically we use these in areas that are lacking high quality microscopes because it doesn't type the malaria for you. It just kind of tells you that it's there. So that's not very helpful. You can also do serological testing. But serological testing isn't very helpful for an acute diagnosis, right? Because it's going to take your body a while to develop and build antibodies. And those won't be detectable for about like 1 to 2 weeks after the primary infection. So it basically, it's not great. Also, it doesn't technically tell you that the patient has malaria right now. It just tells you that they had malaria kind of sometime in the last 6 months to a year. Yeah, so just like knowing that they had an exposure to the plasmodium in the last 6 months, not super helpful in an endemic region. Okay, awesome. So now you know, oh, I have this traveler with a fever and I've confirmed that they have malaria. Now what the fuck do I do? Oh, obviously your treatment is going to depend on which of the fucking plasmodium species your patient actually has. But the other things you want to consider are things like the side effects, the costs, the dose schedule. And also different regions are exhibiting newer resistances to chloroquine. So you have to be mindful of whether or not the strain is resistant. I said strain. We know I'm talking about a parasite. Fuck you. And also, I'm going off of RCSI's little, like, how to treat malaria things. This is going to be some bull hockey, but we're going to go. So let's start with the general stuff, and then we'll move down into specific treatments. So you obviously want to be frequently assessing for good vital signs, right? Malaria can flip really suddenly. You don't want your patient to crash and die. It's a very logical sentence. Supportive treatment as necessary, fluids, O2, you want to have special considerations because of the potential renal implications. So you want to watch for dehydration, hypoxia, hypoglycemia. I literally just said that. Obviously febrile control, especially if the patient is reaching over 39 degrees Celsius. You want to do daily thin film, blood smears to measure the parasite count. Try and grab central venous and central arterial access early. Rather than later, and then keep an eye out for opportunistic infections, obviously, because it is, it's fucking them up. So, consider cultures. I don't know why I said all of that. I could have just been like supportive care. This is the RCSI way. I'm sorry. When you have a patient with malaria, general considerations, supportive care. Sorry. Let's talk about useful treatment here. I'm going to break treatments into tertian and quatrin, and then our other like special things, special groups. Yes, this is a lot. Bear with me. We're going to get through it. And if we don't worry about it. I'm going to start with Vivax and Ovale, our tertian malarias. And luckily we use the same treatment for both. So you're going to start with chloroquine or hydrochloroquine, right? And then you'll add primaquine or tafenoquine. I hate drug names. And that's to eradicate the hypnozoites, right? And prevent the relapse. Simple enough. A chloroquine and then one of the other two drugs to kind of target the hypnozoites. But obviously, it can't be that simple. So you have to remember, there is emerging chloroquine resistance. So then what are you going to do? So in that case, you're going to be using an artemisinin combination therapy or the other ACT. And these are usually a combination of two drugs that I will struggle to pronounce. So, our examples are artemether and lumefantrine or artesunate and amodiaquine. There are a bunch of different ACTs. And we either use those or we use mefloquine. Listen, look it up on a flowchart somewhere. Your hospital will have a protocol. I hate this. Anyways, so you'll either use an ACT or if that's not available, you'll use mefloquine. And then you'll add in primaquine or tafenoquine, right, from before because we still need to, attack those hypnozoites. So that's our treatment for Vivax and Ovale are tertian malarias. So we're going to talk about our quatrin malarias, and we actually just throw in Nolesi in here because I hate it and it sucks, but whatever. It has the same treatment plan as P. malariae, which is good because one less thing to remember. So these will actually be simpler because you don't have to worry about trying to get those hypnozoites. So it'll be chloroquine or hydroquinone or an ACT. You could do a quinine combo therapy. If you have nothing else, then you can use mefloquine. Good news is they're not demonstrating the same kind of resistances, which is, awesome. And, those are our treatments for tertian and quatrin malarias. And if you noticed that we're missing a pretty big malaria in there, good job, gold star. Let's talk about falciparum. I saved the most complicated for last. So falciparum, you can either have it as chloroquine resistant or it can be not. And then you can also have it as uncomplicated or complicated, right? So there are basically like 4 different versions of this. If you remember back in clinical features, I basically said that severe malaria is a potentially fatal manifestation of malaria. And while it is technically, you can technically see it with all of them. You see it most commonly with falciparum. So it is, like I said before, the shittiest. I'm going to try and break this down as simply as possible, but it's not simple. So if you don't understand what the fuck I'm saying, don't worry about it. Let us start with falciparum, uncomplicated, chloroquine sensitive. Treat that with chloroquine, obviously, or hydrochloroquine. So the other thing then is falciparum uncomplicated, but it's chloroquine resistant. So that's when you're going to use something like your ACTs, or you can use, I cannot pronounce this, atovaquone proguano. Sure. You can also use a quinine, but then you add doxycycline or tetracycline or clindamycin. It's like there are a lot of options. There are a lot of treatment options. Your hospital will have guidelines. Just consult those. Don't memorize this shit. It's dumb. Those are for uncomplicated malaria. Now let's talk about complicated, right? It's falciparum, but it's severe this time. First thing we're going to do is we're going to go in IM or IV with artesunate, and it'll be 3 doses, and then you'll reassess after like 4 hours after the last dose. Okay, and your smears here are actually super important because a falciparum patient with an otherwise uncomplicated presentation but has a hyperparasitemia of greater than 2%, we treat them like they're complicated, right? We go in because we're going to treat it like it's severe because it's a bad sign. If after treatment, the parasite density is less than 1%, then we can switch back over to things like, if the patient can tolerate it, you can switch them over to oral ACTs and things like that. There are some other treatments for severe malaria, but I'm very anti just like randomly memorizing drugs. So if you care about that, Google it, I guess. You want to remember the thing that is important to remember is that falciparum and more recently Vivax and Ovale to like a lesser degree are exhibiting levels of chloroquine resistance, right? So you need to be making sure that they are chloroquine sensitive before you treat them with chloroquine. I'm really bad at geography, but for falciparum, I can tell you that regions that like don't demonstrate that resistance are the Caribbean, Central America, and the Middle East. So when you have patients with malaria from there, you can reasonably assume that chloroquine is going to be functional as a treatment. Awesome. Now we know how to treat malaria. We're done. Haha. No. Special patients time. Well, let's talk about patients who are pregnant and contract malaria. So first things first. Pregnant patients are at extremely high risk of hemolytic anemia, especially in their second trimester, particularly if they're prima para. Prima para just means that it's their first time being pregnant. Literature is going to say that there is a 10-fold increase of mortality in patients who are pregnant with malaria, right? They are at higher risk for things, not just for hemolytic anemia, but things for like hyperglycemia, pulmonary edema, and on top of that, super high rates of spontaneous abortion, stillbirths, and premature delivery. And if you manage to overcome all of that and deliver a baby that is, alive, they tend to have low birth weights, which is not good for the child. Clarity, that was hypoglycemia, and also when I said patients who are pregnant with malaria, I meant patients who are pregnant and also have malaria, not patients who are pregnant with malaria. Anyways, basically, it's not an ideal time. It's not a good situation. I don't think being pregnant has ever sounded good, but you definitely don't want to be pregnant and also have malaria. And the reason for this is here. So malaria actually has a subpopulation which is going to bind to chondroitin sulfate A, which is this thing that is presented on the placenta. Like a slightly less confusing terms, hopefully. There's basically a malaria subpopulation that's going to preferentially sequester itself and multiply in the placenta, right? So that causes these high rates of parasitemia and also deleterious effects for both the mother and the child because the placenta is getting fucked. So good news is quinine infusions, I was supposed to say infections, seem to do a pretty good job at like fixing/treating this. And they don't seem to have harmful effects on the fetal function. But in order to do that, you have to diagnose the fact that the patient has malaria pretty quickly, which you won't do. Also, malaria drugs just have like a whole suite of uncomfortable side effects. So, like, just, if at all possible, keep your pregnant patient out of an endemic region. That's the ideal treatment here. As a general rule, it is usually better to just not get the disease than it is to treat it. Which brings up a good point. Why don't we talk about preventions, right? Like, fuck treatment. Let's talk about prevention. First things first, malaria is spread through mosquito bites. So, easy solution, don't fucking get bit by a mosquito. I'm kidding, obviously. I mean, I'm not. That is that is true, but obviously you can't just like will yourself to not be bitten. So, wear protective clothing, use mosquito repellent, reduce breeding sites like pools of water. There's a bit in the Amboss thing here that just says, exercise particular caution after sunset because Anopheles female mosquitoes are more active at night. But that's great, but that's such bullshit because there are other mosquitoes that are active during the day that carry other diseases that are equally as bad. The real advice here is don't fucking get bit. I know we're all very like pro environmental stuff, save the trees, etc., but if you can spray with insecticide and you live in an endemic region, do it. The other prevention is obviously malaria prophylaxis, and this stuff should be initiated before a patient travels to an endemic region or an area of high risk, and you want to use the drug of choice is obviously going to be tailored to the region, right? For example, in a region with falciparum and chloroquine resistance, you're using that drug that I can't pronounce, which I'm just going to call AP, but it's a tovaquin. Fuck you. If there isn't chloroquine resistance, you can use chloroquine. That's an easier one. I should have gone with that. For pregnant patients, since we were talking about that before, the only prophylaxis that has been like that is safe to use is chloroquine or mefloquine. And obviously that's not going to be effective in a region that has chloroquine resistance. Also, mefloquine just kind of sucks ass. It's an uncomfortable drug. Really, if you are pregnant and you don't live in an endemic region, don't go to an endemic region. That is the ideal treatment. Prophylaxis is great and all because it suppresses the cause of the disease and the symptoms, by killing the parasite, before that parasite fucks up your whole life. But it doesn't actually stop you from being infected. Top of that, the prophylaxis isn't going to work for all 5 Plasmodium species, right? You have to target it against the region. And if you miscalibrate or you mess that up, the patient's going to get malaria anyway. Prophylaxis also sucks because it sucks. You feel me? It's an uncomfortable experience. I'm not going to run through all of the side effects of all of the different prophylactic drugs, but just understand that there are a lot of side effects to all of the different prophylactic drugs. Pretty much all of them tend to give patients GI distress. Some will have nausea, vomiting, diarrhea, etc. Some will get rashes. Some will even develop minor fevers. So compliance with prophylaxis for malaria is really bad because taking the medication makes you feel like shit. Also, a lot of people don't finish the course because they don't understand the prophylaxis correctly, because they think, it stops me from being infected. So when they leave the endemic region, they stop taking the prophylaxis, which doesn't work, right? Because remember I said that 7 to 30 day incubation period, and also prophylaxis doesn't stop you from being infected. So if you've just recently come back from an endemic region and you stop taking your prophylaxis, 15 days later, you might be presenting with malaria. Another fun side effect fact is if you're using artesunate or primaquine, you need to screen your patients for G6PD deficiency because they will predicate a hemolytic crisis, which is bad. Check your patients for G6PD deficiency before you prescribe those drugs. Honestly, we could talk about side effects for a really long time, but who actually wants to do that? So just understand, malaria prophylaxis, it's pretty shitty and compliance is poor. Okay, so that's kind of that on that. We're going to talk about a couple of other things because they're interesting and I want to, and this is a study tool for me. So, haha. Things first, some patients will exhibit partial immunity to malaria, right? Carriers of the sickle cell mutation have some innate immunity, particularly against falciparum. Having certain Duffy antigens or having no Duffy antigens confers some resistance to Vivax and Nolesi, since they use Duffy antigens to sort of invade the red blood cell. Other hemoglobinopathies can help, so things like thalassemia or HBC, those both confer some amounts of immunity. Finally, if you have been recently infected with malaria, you do appear to gain some partial immunity for a limited amount of time. So we don't know the exact amount of time. It's less than a year. And you can be reinfected, but the disease will be less severe. So I think that's pretty much everything that you need to know about malaria. Fuck, wait, no, malaria, it's a reportable disease. All laboratory confirmed cases of malaria should be reported to your local state health department, or whatever your country's equivalent of that is. So now, that's everything I think you should care about for malaria. And as always, the best treatment is to not get sick in the first place. So let's go hang some mosquito nets and